Hello everyone, and welcome to the CCHD Screening and Reporting in the Neonatal Intensive Care Unit and Special Care Nursery webinar. Funding for this program was provided by the New Jersey Department of Health. My name is Lindsay Caparino, Administrative Assistant for the CCHD program here at the New Jersey chapter of the American Academy of Pediatrics, and I will be moderating today's webinar. Before we get started, I would like to go over a few housekeeping items. Today's webinar will last approximately 1 hour. All attendees will be muted throughout the webinar in order to minimize any disruptions. There will be an opportunity at the end of the webinar for Q&A. If you have questions about the subject matter, we ask that you submit them in the question box on your webinar control panel on the right of your screen. The webinar is being recorded and will be made available on NJAAP's website for future reference. Now, without further delay, let me turn the webinar over to our presenters, Regina Grizel and Dr. Kim Van Arden-Braun.
Good afternoon, everyone, and welcome to the webinar. My name is Jean Grizel. I'm the Program Director for the New Jersey Department of Health CCHD Screening Program and Infant Zika Surveillance. And we're here at the New Jersey chapter of AAP providing this webinar on guidance for implementation and reporting of critical congenital heart defect screening in the NICU and the special care nursery. So as you recall, New Jersey was the first state to implement CCHD screening back in 2011, and since then we've had questions about how to implement it best in the NICU. So that is the focus of our webinar today, and we'll talk about implementing CCHD screening and also how to properly report it. So I'm going to turn it over to my colleague, Dr. Kim Van Arden-Braun, to begin today's presentation.
Thanks, Jean. Good afternoon, everyone. I'm an epidemiologist with the Division of Congenital and Developmental Disorders with CDC, and also stationed with Jean at the Division of Family Health Services at the New Jersey Department of Health. So we appreciate everyone's participation in today's webinar. By means of a refresher of background, in the United States, about 2 per 1,000 infants annually have a critical congenital heart defect. And as you know, delayed detection of a CCHD may result in significant morbidity or mortality. Therefore, early identification and intervention is really crucial. As you can see from the map on the right, screening for early detection of CCHD using pulse oximetry is near universal in the United States. Yet most states require screening of all infants, irrespective of their clinical status or setting. And so this poses, as we know, unique challenges in the NICU, but limited evidence exists to guide implementation. And to this day, since implementation, and even given that screening is near universal, guidance for NICU screening is quite limited. So the evolution of our legislation was really that in 2011, our legislation required that all birthing facilities licensed by the Department of Health were to perform pulse ox screening for congenital heart defects at a minimum of 24 hours after birth on every newborn in its care. And when the Department of Health put forth a recommended screening protocol, there was verbiage at the bottom, in addition to the decision tree of the algorithm thresholds, that stated in the NICU, screening should be performed at 24 to 48 hours of age or as soon as medically appropriate after 24 hours of age, and that it must be performed prior to transfer out of the hospital if the transfer occurs at greater than or equal to 24 hours. And in all cases, screening should be performed prior to discharge home. And at the time the algorithm was created, we compiled a stakeholders group, a working group of experts, and this is the wording that we came up with in the beginning of implementation. So this was not based on empiric evidence of the time, based on best estimation of how NICU screening should occur. To give some findings from the New Jersey Birth Defects Registry of the number of fails that have been reported as of March 31st of 2017, we've had 338 fails reported to the Birth Defects Registry, and interestingly, 39% were screened in the well baby nursery, but the majority, 61%, were actually screened in the NICU. And as you know, the legislation was truly targeted for the well baby population to identify unsuspected CCHD, and yet the majority of fails were found in the NICU. What we presented here is the distribution of gestational age overall, so for all of our fails, and you can see that 76% were normal birth weight babies greater than or equal to greater than 2,500 grams, and that in the NICU population, approximately 62% were also normal birth weight babies. And so this is demonstrating that even within the NICU, the majority of infants are normal birth weight. So now we're going to focus on restricting our failed screens to those that were screened in the NICU. Of those, that 62% represented 206 infants that failed and were residing at the NICU, in the NICU at the time of their screen. 20% had an evaluation that was due to the screen. The remaining 80% were what we call pre-identified. So these were infants that had a prenatal diagnosis of a CHD, signs or symptoms at or before the time of the screen, or a cardiac consult or echocardiogram prior to the screen. So we categorize these three indicators as pre-identified infants such that the screen didn't have an impact on subsequent evaluation or identification of a condition. Looking closer at the 20% who had an evaluation specifically due to the failed screen, we found one infant with a CCHD that was previously unsuspected prior to the screen. And we found 9 infants with a larger umbrella CHD, so a non-critical congenital heart defect. Interestingly, 5 of the 41 infants with an evaluation performed in response to the failed screen had an echo with normal findings. So these would be what we consider false positives, and that number was very low. More specifically, the one CCHD that was unsuspected prior to screening was a mild coarctation of the aorta, and the 9 CHDs were comprised of 3 VSDs, 2 ASDs, 3 infants with peripheral pulmonary artery stenosis, and 1 atrial septal aneurysm. We also identified 15 PFOs or PDAs, and these were the diagnoses upon discharge. And then there were 16 incomplete screens. So what this represents are infants that failed the first screen, but that the subsequent screenings or rescreens did not occur. So these are considered incomplete screens. So a number of years ago, we convened a working group of specialists in New Jersey primarily to discuss this issue of, do we modify our algorithm in New Jersey? Do we continue our current protocol for implementation in the NICU? And the consensus from this day-long meeting was that the research is too limited on NICU screening to actually provide guidance and recommendations, and that population-based empiric evidence is needed to actually formulate recommendations, and that further study was warranted. We took this as, let's do something and see what we can compile to actually get some empiric evidence to guide implementation. The New Jersey Department of Health led an evaluation with 2 objectives: to assess the NICU population and potential modifications to the screening algorithm. So what we did was we evaluated the feasibility and burden associated with, 1, early timing options for screening, because timing is not specified explicitly in the current algorithm for NICU infants, and then to evaluate exclusion criteria. So whether infants with a prenatal CHD diagnosis and echo conducted before the screen, or those born extremely premature, could actually be excluded from the universal screening for CCHD. Our methods included a prospective evaluation implementing a multi-stage modified CCHD screening algorithm, and we also conducted an implementation survey from nursing staff. While we originally started with 9 NICUs in New Jersey, the issue of NICU screening really is a national discussion, and so NICUs from California, Illinois, New York, and Minnesota came on board wanting to really join this effort to better understand this population. Our population of infants that participated in The evaluation was a little over 4,500 infants, and the study occurred over a 9-month period. And what was interesting was that 4,100 infants, roughly, had a complete set of appropriately timed screening. So you can see that there's a difference between the infants that participated, so that were in the NICU with a stay of greater than 23 hours, and those that actually had a complete set of screening results, speaking to, off the bat, the complexity of screening in the NICU. Brief overview of our multi-stage algorithm was that we modified it for infants on oxygen. Stage 1 screening was targeted for 24 to 48 hours after admission, and for infants on oxygen at 24 to 48 hours, rescreening was only required if the differential between pre- and post-ductal saturations was greater than 3%. If saturations were less than 95% and consistent with the clinical profile of the infant, that result was considered a conditional pass. If the saturations were less than 95% and inconsistent with clinical profile, then that was regarded as a fail. Stage 2 was conducted for those infants that were on oxygen at stage 1, and this was performed optimally within 24 to 48 hours after the infant was weaned from oxygen. If no other screen was done prior to discharge, then a screen was done pre-discharge because we wanted to ensure that all infants were screened before they left the hospital. This is the picture of our evaluation algorithm that it was again specified specifically to answer our evaluation objectives rather than us trying to endorse this as what would be professed as a modified algorithm. What were our results? We found that the majority of NICU infants were born normal birth weight, 56%. 72% were not on oxygen at stage 1, and 92% did not have one of the 3 pre-identifying factors that I had described. When we combine some of that information, 68% of infants had neither a pre-identifying factor and were not on oxygen. So this is comprising the subgroup who may benefit from early screening. Overall, our fail rates for stage 1 and stage 2 were actually low, 0.9% and 0.6% respectively. Not surprisingly, despite the modification, stage 1 fail rates were significantly higher for infants on oxygen at 2.1% than those on room air at 0.7%. When we took our conditional passes and considered them fails, under the current non-modified algorithm, they would be fails. This increased our fail rate for infants on oxygen to approximately 26%, so extremely high. Stage 1 fail rates were highest among infants born extremely low birth weight, less than 1,000 grams, or extremely preterm, less than 28 weeks, and not on oxygen, 7.4% and 9.5% respectively. And this was notably higher for these 2 groups when conditional passes are considered fails. When we look at the characteristics of our failed screens, of the 32 infants that failed at stage 1, 63% were not on oxygen, 66% did not have a pre-identifying factor, and we actually identified 1 infant with previously unrecognized non-critical congenital heart defect, and this was a VSD that was detected by the screening. Of the 5 infants that failed stage 2, 40% did not have a pre-identifying factor. So you can see the common theme that even among our fails, the majority were not on oxygen and did not have a pre-identifying factor. We did not, though, identify an infant with previously unsuspected CCHD identified by screening. We measured feasibility and burden using 3 different metrics and methods. We assessed false positive rates. We found that overall, for both stages, the false positive rate was 0.8%, slightly lower for non-pre-identified infants at 0.6%. It's difficult to compare our estimates to the existing literature because the existing literature and the body of that is so minimal, But when we compared our estimates with existing literature, there's one study that examined well infants screened using upper and lower extremities at greater than 24 hours without a prenatal diagnosis. So criteria that were most similar to our evaluation, and the false positive rate for that study was 0.2%. So when you look at our overall false positive rate of 0.8% is not tremendously higher than 0.2%, which was found in the well baby population. The false positive rates were highest among infants screened on oxygen, 2.1%, and those born extremely preterm at 3.8%. Yet significantly lower for infants screened at stage 1 not on oxygen, 0.5%, and stage 2 after having been weaned from oxygen at 0.6%. The second measure we obtained for assessing feasibility and burden was the proportion of our infants with an unnecessary echocardiogram. So approximately 13% of infants in our evaluation had an echo during hospitalization, but only 7 echoes, or 0.2%, were performed in response to the failed screen at any stage, keeping in mind that one of these echoes actually identified a VSD. So this number is extremely low and speaks to the very low burden of unnecessary echocardiography. The third measure of feasibility and burden was the implementation survey that I mentioned. 258 nurses responded to this survey, and the nursing staff reported low burden during the evaluation. This was on a Likert scale of 0 equaling no burden to 10 extremely burdensome, and the mean was 3.5. We also found that 80% of nursing staff reported that a NICU-specific CCHD screening protocol helped differentiate between screening and routine monitoring with pulse oximetry in the NICU. 81% responded that utilization of the evaluation protocol also increased awareness of unsuspected CHD in the NICU. So changing culture and increasing the awareness of the potential for unsuspected CHD, despite the fact that the infant was being closely monitored in the NICU. But one important point was that tracking, screening, and results from the multi-stage algorithm that was implemented in our study was quite challenging. So this was a very important take-home point as well. What are our conclusions? Given that the NICU population consists largely of normal birth weight infants, those not receiving oxygen, screening at 24 to 48 hours may provide benefit for early detection of CCHD for the majority of NICU infants that closely resemble the well baby population for which the screening was initially intended. Exclusion of subpopulations introduces practice variation, potentially leading to missed screens. So another important point that not only did our subpopulations that we were evaluating to assess for being potentially excluded from screening, not only were those proportions very low, but feedback from the evaluation was that introducing variation for these very small subpopulations could lead to potentially missed screens, which we obviously don't want. Yet it was noted that challenges when early screening occurs for infants born extremely premature and or those receiving supplemental oxygen were present and need to be addressed clearly in terms of implementation and further research. But in conclusion, our evaluation and the principal investigators from this study all concurred that systematic early screening does not incur significant burden and may actually provide benefit for early detection of CCHD. Now I'm going to turn it back to Jean to recommendations for implementation and reporting in our state.
Thanks, Kim, for that overview of the evaluation of CCHD screening in the NICU. And the findings from this evaluation have been very beneficial in helping to inform guidance and recommendations for how we screen our babies in the NICU in New Jersey. So you should have received this attachment. It's a one-pager summary of the guidance for how to screen in the NICU and how and what to report. So this is available to you as a reference, and I'm going to walk through the recommendations. So the first question was who to screen. Our legislation, as Kim reviewed in New Jersey, requires screening of all infants at minimally 24 hours. So our evaluation, the findings, the conclusions of the evaluation have shown that the burden for screening all babies in the NICU is quite low. So our expert working group did not make any recommendations in terms of administrative rules specific to screening in the NICU. So we will continue to screen all infants, including those with a prenatal diagnosis of CHD, babies who have received an echocardiogram before the time of the screening, and those babies who are being transferred out at minimally 24 hours or greater after birth. So when do we screen in the NICU? Some of you participated in a survey that the New Jersey NICU Collaborative worked with the New Jersey Department of Health to implement, and we found that screening was very, very variable in terms of timing. The results of the evaluation have helped us to strengthen the recommendation to screen as soon as possible in the NICU. So optimally screen at 24 to 48 hours if the baby is medically appropriate. If the baby is not able to be screened at 24 to 48 hours, then perform the screening as soon as possible when medically appropriate. And to screen infants after weaning from respiratory support, and this would include supplemental oxygen and weaning from rooming or CPAP. So that's a little bit on who and when to screen. So what about reporting? So as you know, the Vital Information Platform, or the VIP, was implemented, and screening results for all babies are captured in the VIP. Screening results up to all 3 attempts, if they were performed, should be entered. For all failed pulse oximetry screens, they are reported to the New Jersey Birth Defects Registry. So if the baby failed the screen, the failing results should be in the VIP, and then a complete pulse ox module is completed in the New Jersey Birth Defects Registry, and this gives us details about the fail. If a baby has CCHD confirmed with an echocardiogram, we understand that as a special situation, but all babies must have screening results in the VIP. So for babies that have CCHD, one set of pulse ox measurements needs to be entered into the VIP, and then again, if they have failing results, then they should be reported to the New Jersey Birth Defects Registry. In the cases where the baby has had a CCHD confirmed with echocardiogram, one pre and post ductal measurement is sufficient. You wouldn't need to keep repeating the screen. So what to report in terms of transfers? If a baby is 24 hours of life or greater, they are included in the mandate, and at least one set of measurements should be entered into the VIP, and any failing results are reported to the New Jersey Birth Defects Registry. Understanding that the screening should never interfere with clinical management, and so we wouldn't want a transfer to be held up because we were following the screening protocol. So in this case, if a repeat screen is not feasible for a result between 90 and 95, if a repeat screen is not feasible, it does not need to be completed. We would just need one set of measurements. And another point is that with transfers, the VIP record should be transferred to the receiving hospital if appropriate, so that additional screening results can be added to the record. The VIP record can be transferred within hospital systems. So if a baby is transferred at less than 24 hours, this situation is not included in the mandate. However, we wouldn't want babies to be missed with screening. So screening is recommended shortly before discharge or transfer. And again, one complete screening pre and postductal is sufficient. And the recommendation is strong, especially if the baby's being transferred out of state. So again, it's not included in the mandate, but the recommendation is, if feasible, to perform screening. So where can you find more education and resources? The New Jersey Department of Health maintains the CCHD screening resources webpage. You can download your copy of the Clinical Congenital Heart Defect Screening Guide. It contains updated information, including how to screen and report in the NICU and special care. It also includes all those parent handouts in 5 languages. Resources are available on the JAP website. I want to acknowledge now all those who participated in the evaluation at the 21 sites, and the PIs are listed here, and we thank them for their participation. And I also want to acknowledge the NICUs themselves, and the sites are listed here. We know it takes a lot of cooperation, and a lot of nurses contributed to the screening evaluation. We also want to thank the New Jersey NICU Collaborative, who really partnered with us early on this journey to understand best practices for CCHD screening in the NICU, as well as our New Jersey chapter of AAP here, the New Jersey Department of Health, and Rutgers Office of Continuing Professional Education, who helped us immensely with the study evaluation tool. So here's my contact information. You can always reach out to me if you have any questions pertaining to CCHD screening. And we are going to open it for questions now. I'm going to turn it over to Lindsay, who will just remind you how you can submit your questions.
Okay. Thank you to our presenters for providing such an informative presentation. Once again, this presentation will be available on NJAAP's website later this week. Once again, if you have any questions, please type them into the question box on the right-hand side of your screen in your webinar control panel. If you have entered your audio PIN, you can also raise your hand electronically by clicking on the hand icon on your control panel, and we will call your name so you can ask your question yourself.
So I'm going to pose a question. This is Jean. So for those of you who are on, are you currently screening as much as possible at 24 to 48 hours, or are you waiting to closer to discharge? Our conclusions from the evaluation show the benefit of screening whenever possible at 24 to 48 hours, or screening earlier, such that 24 to 48 hours after the baby's weaned from oxygen. So to prioritize the screening sooner rather than later. Okay, so we have a question that came in. Please clarify if infant on supplemental O2, they should be screened at 24 to 48 hours, and again when weaned from O2 or support. So we found that there was a higher false positive rate when the babies were screened at 24 to 48 hours on oxygen. So although your hospital protocol may do additional screening, the recommendation is that the babies are screened when weaned. So screened, within the 24 to 48 hours of being weaned. Another one, we currently screen babies in the NICU 24 hours after discharge of oxygen. Okay, that would be in line with these current recommendations then, yes. So for babies not on oxygen, because our study showed that actually most babies were not on oxygen, and the bigger babies. And so they approximate the group like the well babies. And so implementing screening for those not on oxygen and medically stable at 24 to 48 hours is recommended. One of the things that was expressed on the survey from nurses was this idea of tracking. So screening should be performed for those not on oxygen, like I said, as soon as possible at 24 to 48 hours. But for those on oxygen, to screen after they wean. And so this does kind of present somewhat of a challenge in terms of tracking those babies. So, somehow flagging them in the medical record, babies that are due to be screened, so that it's not coming time for discharge and we find that they're not screened.
Okay, I see Susan Russell, you have your hand raised. I'm going to unmute you now if you'd like to ask your question.
Yeah, we just had a question about entering the information into the Vital Information Platform. Does it need to be entered when the results are obtained or at discharge?
So ideally, the results are entered for the first release. So if you can get them in sooner rather than on discharge, that's ideal, because as we know, the length of stay could be quite lengthy. So there are different release points of the VIPs. So one of the earlier release points is ideal rather than at discharge. Although if you have a short stay baby, that's going to coincide with the same deadline, in terms of a short stay baby. If you have a long stay baby, if you have the screen performed, it's ideal to get the results in the VIP.
Okay, all right, thanks.
And, and especially if it's a fail, because it's very important for the birth defects registry that we are notified of the fails as soon as possible. So the results that Kim shared with you are due to the analysis of the data that we have entered into the birth defects registry. And that's where we can share how many fails, what were the findings of the babies who failed. So getting the information into the BDR shortly after the fail is really important. So thank you. There's another question. Will this presentation be available for printing? We are recording the webinar. I guess that's in regards to the slides. We can post the slides as well, yes. So we've had situations where babies were on nasal CPAP, room air, and that was thought to give enough respiratory support that we were recommending to wait until they were weaned and provide the screening as soon as possible, 24 to 48 hours after weaning. If the baby is on nasal cannula room air, it's really a clinician's call as to if that is considered respiratory support. It would not necessarily interfere with the pulse oximetry readings. So we often otherwise have questions about, sometimes babies are being weaned and to room air and then they're going back on oxygen, so it's kind of a back and forth situation. If there's a stretch of time where the baby's stable, where you can get the screening, again, it's better to screen earlier in their hospital course. That way, if there is a critical defect, it can be identified. If the baby is very sick or unstable, this is not, the time to prioritize the screening. So sometimes I get questions about, well, the baby failed, but we expected the baby to fail. Do we still have to report it? So for instance, the baby's being transferred out and the baby's on a ventilator. And so the saturations are less than 95. Do we have to report that? And yes, it's important to report all failing results to the New Jersey Birth Defects Registry. And then all the results are analyzed and looked at. So for those babies who require respiratory support, that they already have one of the pre-identifying factors that Kim spoke of, whether it was a prenatal diagnosis, so we know the baby had a congenital heart defect already, so the baby presented with symptoms prior to, whether they're cardiac symptoms, respiratory symptoms. Those questions capture that situation in the birth defects registry. So just be sure to report all the details, and it's easy for us to make distinctions about the role of the screening to the identification of the defect. So we have had babies in the neonatal intensive care unit who have failed their screenings and have had conditions identified. We did have one baby with a coarct identified, and we had a handful of babies with other congenital heart defects from the NICU identified because of their screening. So if there are no further questions.
Thank you all for your input. If you have a question that you would still like to have answered, please email us. On behalf of the New Jersey Chapter American Academy of Pediatrics, I'd like to thank you for joining us today for this webinar. Thanks once again to Regina Grizel and Dr. Kim Van Arden Braun, and to all of you for taking the time to participate in our webinar. This concludes our webinar.